Okay, so we're going to move right into our first program or first lecture today, and that will be given by Dr. Katharine Barr. She is an associate professor of medicine at the University of Pennsylvania. She completed her medical training at the University of Iowa College of Medicine, was chief resident in internal medicine at the Medical College of Virginia, and an infectious disease fellow at the University of Alabama at Birmingham, and trained in the laboratories of doctors George Shaw and Beatrice Hahn. She has joined the University of Pennsylvania faculty in 2012. And as an infectious disease physician and a translational physician scientist, she studies the basic mechanisms and impact of virus transmission, pathogenesis, and persistence of HIV. She's also been involved, obviously, as many of us have, in the SARS-CoV-2 pandemic and other viral pathogens. And her recent work aims to understand virus-host interactions and develop antibody-based HIV cure interventions. So Dr. Barr is going to talk to us this morning on update on the cure from in between days to just like heaven, although I'm not sure we're quite to heaven yet, but thank you, Dr. Barr.
Thank you so much, Connie. All right, my title was just a sort of vain attempt to reference songs from The Cure and to highlight my Gen X-ness. I would just want to say it's so wonderful to be here in Chicago. I actually went to college here in Chicago in the 1990s. And although I'm a little bit young and perhaps not esteemed enough to have ever worked with Dr. John Fair, I was deeply influenced by his daughter, the infamous Liz Fair, and I have memorized her first album, XI and Guyville. And if anyone wants me to sing from that, I will, but it will be awful. But it'll still be. So anyway, I think maybe the secret dream of all, this personally speaking, a very nerdy infectious disease person, is that maybe my children will grow up to be rock stars. So in that regard, we'll get going. Hope to keep this light. All right. It is very hard to come to a clinical conference and have someone stand up here and tell you about HIV cure. Why is that relevant? Well, let's see if we can figure that out. Learning objectives. So I'm hoping to frame this in things that your patients may ask you, and so you can have some talking points to share with your patients. And so what we're going to talk about are examples of HIV cure, from stem cell transplant to natural immunity. We're going to describe some gene therapy approaches that are currently in development. We're going to talk about recent trials of broadly neutralizing antibodies given either at the time of ART initiation or after early ART initiation. And hopefully these will be good ways to communicate with our patients about cure. Okay, so this is a hypothetical young person with HIV who's had a routine clinic visit with you, and they say, "Doc or provider, what is going on with HIV cure? I know antiretrovirals are amazing and improving all the time, but am I going to have to keep taking ART forever?" And so again, these are the things we're going to talk about. Here's a framework of how you might be able to talk about cure with your patients. So we all know that antiretroviral therapy is a modern miracle. It stops virus replication and therefore enables return to health and prevents ongoing transmission to any partners of a person with HIV if virus is suppressed. However, if we stop antiretroviral therapy, in the vast majority of individuals, virus comes back. And that is because antiretroviral therapy does not eradicate the persistent reservoirs, the long-lived virus-infected cells that are throughout our body in sufficient quantities such that they will reactivate and restart virus replication very quickly in the vast majority of individuals. So the goal of HIV cure is to render ART-free virus control. And we do that generally through two mechanisms. One, we look to clear or substantially reduce the number of those long-lived virus-positive cells, and to enhance our immune system to better control virus rebound, virus replication. So in natural HIV cure, which we're going to review today, this happens largely through both of these mechanisms. We see much smaller and less diverse reservoirs, and we see more robust immune responses against HIV. In the most common documented cases of interventions that have led to HIV cure, and that's stem cell transplant, that is done largely through eradicating the reservoir with much less of an immune response. And so we're going to talk about how gene therapy strategies are attempting to reproduce that version. Okay, so if we think about our well-reported examples of cures, of HIV cure, and again, this list is growing and it's hard to fit all of these individuals on one slide, but these are proof of principle, small numbers of people who have been cured by stem cell transplant or other mechanisms. But the vast majority, again, are stem cell transplants. And so this has traditionally been done with individuals who receive donor cells from a person who has the Delta 32 CCR5 mutation. So their cells do not express CCR5, therefore are resistant to HIV. But I just want to highlight there have been small numbers of reports of individuals with stem cell transplants with wild type cells that have also gone on to HIV cure. And so that is a new event that's happened just in the past couple of years. But if we think about stem cell transplant, largely with CCR5 Delta 32 donors, the basic concept is this is people with HIV who have a cancer diagnosis, and it's only the cancer diagnosis that leads to the stem cell transplant. But because of registries we have of people, of donors with CCR5 negative cells, we are able to do transplants with these HIV resistant cells. And after extensive systemic chemotherapy, and oftentimes graft versus host disease, which leads to further reduction in the original cells from the individual, and a combination of different immunotherapeutics. Many times after these transplants, reservoir measures are negative. And after a discussion between the patient and the care team, there's a stopping of antiretroviral therapy. And in these cases, what we've seen is durable remission and no ability to detect any cells with replication competent virus. So again, this is not a scalable approach. This is proof of concept, but it's inspiration for many ongoing gene therapy approaches. And so one of those approaches is, can we, via multiple approaches, render cells in the virus resistant to HIV? And so there's both ex vivo and in vivo editing strategies to try to get CCR5 off of cells so that HIV can no longer enter them. And so in the ex vivo context, that means people would do like an apheresis, get a large amount of cells, they would be modified in the lab and then reinfused to the individual. And that's the standard approach that we've been attempting to do this sort of thing. But there's new in vivo editing strategies that are being developed so that we can deliver, say, mRNA or DNA or a viral vector to an individual with one shot. That shot can deliver that editing machinery to change people's cells within them. And that's sort of the basis of how we think about these one-shot gene therapy approaches that might be able to deliver new approaches towards HIV cure. So how does this move forward in many different pathways? So in addition to rendering cells resistant to HIV by modifying CCR5, people are also working on CAR T cells or CAR NK cells. And these are chimeric antigen receptor T cells or NK cells. And the goal here is to take our immune system, our CD8 T cells and our NK cells, and make those cells more powerful, more functional, more targeted at the HIV reservoir. So there's multiple, this strategy of CAR T cells is extremely powerful in liquid oncology, less so in solid tumors and less so far in HIV because the antigen it seeks is few and far between, and there's many technological challenges, but people are working on this and it's making real progress. The next concept is, could we deliver, much like that in vivo editing, could we deliver broadly neutralizing antibodies or other sort of immune system properties that could then do their job after just a single shot? And so there's proof of concept of this that has already happened. There was a study by the NIH a few years ago in which AAV or adeno-associated virus delivered BNAbs were administered to adult patients and adult participants, and those people had BNAb levels for years. There are multiple new studies, including one that we hope will continue in the ACTG, looking at this sort of delivery via viral vectors, mRNA, DNA, lots of other sort of novel approaches. And maybe the thing that gets a little bit more sort of publicity in the world of gene therapy is our exonucleases, or things like CRISPR-Cas9. So these are molecules that go into the cell, they survey the genomes, and they clip out and remove and then have the host genome heal little specific parts of the genome. And so for CRISPR-Cas9, but there's other exonucleases like Cre recombinases and BRCA1, et cetera. These things have been shown in phase 1 trials to be safe. There was a recent phase 1 trial of AAV9 delivery of CRISPR-Cas9. It was shown to be safe, but not that effective yet. But this is the sort of thing that's being used in other approaches and in HIV, and has a real possibility to move forward as a single shot approach to make a substantial iterative improvement towards HIV cure. So I want to talk about one study that was published this past year, what I think is a nice example of these types of strategies and how they translate from prevention to cure. Prevention to treatment to cure. And this is a study that was done in non-human primates. It's led by Mauricio Martins from University of Florida, Scripps, Florida. And basically what they did is they used AAV9, this viral vector, to deliver broadly neutralizing antibodies to infant non-human primates or infant macaques. And the goal was to prevent mother to child, or mother to, in this case, non-human primate baby transmission. So they were able to deliver this vector to very early infant macaques. You can see in blue, there was high levels of this antibody for a long period of time. And these infants were able to be protected from repeated oral challenge. So thinking about breast milk transmission. Then they did something interesting, and they exposed the mothers to BNAbs. They gave those antibodies to the mothers that induced immune tolerance. And when they gave that viral vector to the infants, they got even higher and longer levels of those BNAbs that, again, protected against oral challenge. But these infant macaques then grew up to become adolescent macaques, and these adolescents were protected against rectal challenge. And so this is the sort of concept of how one delivery at this critical time where we're protecting babies from transmission from an HIV positive mother could then lead to long-lasting protection through sexual debut, and potentially have long-lasting sort of prevention, treatment. And this is the same sort of concept where we're delivering antibodies that have a role in cure, in cure as well. So I just think this is a really great study that shows how these same technologies can be applied across the spectrum of the ways we're trying to treat and cure HIV. Okay, so back to our examples of HIV cure. I want to highlight two individuals who are extremely well-characterized examples of natural HIV cure. So these are exceptional elite controllers. And so the one I want to talk about, so just review types of HIV control. So again, when we think about what happens in the vast majority of individuals with HIV, antiretrovirals suppress virus, but when they go away, the virus comes back. So when we think about elite control, which is perhaps the best described version of natural control, this is control of early or primary HIV. And this is a rare phenomenon in less than 1% of individuals who have HIV, but the duration can be quite profound. So there are individuals with elite control who have been suppressed on their own for more than 30 years. So what happens is we see a blunted early primary infection. The virus is controlled quickly. We see much smaller reservoirs, and we know that the mechanism is associated with very robust CD8 T cell responses. And this is related to both genetic studies and functional studies of the CD8 T cells in these individuals being exquisitely able to see the virus that that people were exposed to and control it well. The other type of natural control that's even more important, I think, to our modern cure strategies is post-treatment control. So this is a more common phenomenon. And what we see is people who have a normal primary HIV virus and host immune system interaction, they're suppressed on antiretrovirals. And when antiretrovirals are stopped, their viral rebound is muted, and they go on to have their own immune systems control the virus. Now, after early antiretrovirals started within about the first 6 to 12 months of infection, we know the frequency of post-treatment control is much higher, somewhere between 5 and 15%, depending on the cohort. In people with chronic ART initiation, the vast majority of the HIV pandemic, it's less common, about 2% or fewer. And the duration of this is not as well understood. We think it's probably a little shorter, but we've been studying it for a far shorter period of time. And so we're going to have to figure out the duration of this control. The mechanism of this control is also multifaceted. It is not primarily CD8 T cells. In fact, the genetic markers associated with elite control are very different than those associated with post-treatment control. We think this is related to a combination of immune responses, effective NK cells, effective antibodies against the virus, also CD8 T cells, and smaller reservoirs. So our HIV cure interventions for immunotherapeutic cure are really focused on trying to reproduce post-treatment cure through a range of sort of overlapping immune mechanisms. Okay, so back to our example of one of these exceptional elite controllers. So this is a woman who has come forward and been very public about her experience. She is a wonderful altruistic sort of advocate for HIV cure. Her name is Ms. Laureen Willenberg. She lives in San Francisco. She acquired HIV in 1992, or was diagnosed in 1992, basically controlled the virus on her own for 30 years. And here you see her CD4 T cell count in blue. You see her viral load, which is basically at the limit of detection for the assay for all of these 30 years. She's partnered with many cure researchers, and we have been, as a field, unable to detect replication competent virus in her body for more than 20 plus years. But in 2022, unfortunately, Ms. Willenberg was diagnosed with lung cancer. And so in the course of her treatment for lung cancer, she underwent immune modulation, traditional chemotherapy, and multiple aggressive mechanisms to suppress her immune system. And throughout that whole 3-year period of treatment, she has not had any virus reactivate. So this is kind of the most robust stress test for virus being present in her body that we could think of. And fortunately, at this point in time, she's doing very well from her cancer standpoint. And we have further no evidence that she has any virus in her body, making us think she really is an example of this extreme elite control, eradicating the virus from her body. So this was presented at IAS, and there's a lovely article in Science, and she is just a wonderful advocate for speaking about this experience. But this is, again, a model for how we might be able to get immune control to help eradicate the virus. So if we think about elite control, which is what happened in Ms. Willenberg, we see early effective CD8 T cell responses, and that leads to two things. One, we as a cure field are trying to reproduce those robust CD8 T cells. We have therapeutic vaccines. We have checkpoint inhibitors like PD-1 inhibitors that are attempting to reproduce this excellent CD8 T cell functionality. And we have CAR T cells, these chimeric antigen gene therapy modified T cells, trying to reproduce that really effective CD8 T cell response. But we also rely on early antiretroviral therapy to do some of what happened in this individual. We want to limit the size and the diversity of the reservoir, and we want to limit immune exhaustion. So there's been several really important studies looking at the role of early antiretroviral therapy, and I just want to highlight one of them. So this is the SPARTAC ATI study, and many of you may be familiar with the SPARTAC study. It was looking at the role of early antiretrovirals quite a bit ago, but in the context of this study, they had 2 cohorts of individuals, women in Southern Africa and men who have sex with men, largely in Europe, in whom they had early antiretroviral initiation and they were suppressed on ART. And in those individuals, they said, well, if we do a treatment interruption, will the virus be more likely to remain suppressed in these early ART-treated individuals? And it turns out that what happened is there was remarkable post-treatment control in the African women and much less so in the European men who have sex with men. So here in this the Kaplan-Meier curve, you can see time to virus rebound. On the top line is the African women cohort, and on the bottom line is the men who have sex with men in Europe cohort. And I just want to show how different those levels are. Both of these groups of people got the same intervention. And in fact, about a quarter or 5 of the 22 African women who were studied maintained virus suppression off ART for years after this intervention. And so I think this highlights 2 very important features. Number one, early antiretroviral therapy is a very important way to reduce the reservoir size, enhance immunity, and can increase our frequency of post-treatment control. But even more glaringly, This emphasizes the importance of us doing research across the globe in diverse cohorts that are diverse based on sex, geography, virus clade, antiretroviral timing, and other factors. We must characterize a diverse range of people and circumstances in order to be able to provide cure for the entire world. Okay, so let's think a little bit more about post-treatment control, or these individuals who control their virus after we stop antiretroviral therapy. There's two things that we believe are associated with this. First of all, early antiretroviral therapy is clearly important. It makes the reservoir smaller, it makes it less diverse, more able for the immune system to control, and it preserves our immune system without sort of the exhaustion of a chronic infection. There are many different immune mechanisms that are shown to be more robust in people with post-treatment control, and we're still sort of teasing out which are the most important and which are the most reproducible. But these are clearly what we're aiming for in our immunotherapeutic cure strategies. So what I want to talk about is one particular intervention approach, and that is broadly neutralizing antibodies, or BNAbs, either at or after early ART initiation. And so why do we think BNAbs might be important at the time of ART initiation or after early ART? Well, I'm not going to go through the details of this, but there's a large recent body of work that suggests the same features of antiretroviral therapy that return us to health actually allow recently infected cells a much better chance of surviving for a long period of time. And so we think that that stability, the less inflammation, the fewer cytokines allow recently infected memory CD4 positive T cells to do their job and become memory cells that are going to live for years and years and years. And therefore, the reservoir is sort of established at the time of ART initiation. And so this might be a really good time to intervene to block that reservoir formation. It's also a feasible clinical juncture, intervening at the time a person comes to the clinic and says, I'm going to start antiretroviral therapy. They're already engaged in clinical care. That's a time that we could intervene with a cure strategy. Why do we want to use broadly neutralizing antibodies? Well, broadly neutralizing antibodies are called that because they have activity, potent activity against a wide range of viruses. But beyond that neutralization, they're also active components of the immune system. So via the Fc component of the antibody, they're able to engage with the rest of the immune system. And above and beyond antiretroviral therapy, they can help the immune system see and clear virus-infected cells. So our modern ART does an amazing job preventing the next round of infection, but once a cell is infected, antiretrovirals don't do anything to help get rid of that cell. Antibodies can see infected cells and in theory, help remove them via a whole range of immune modalities. Also, antibodies as a part of that functional immune system can engage to make HIV-specific immune responses better. So this is called a vaccinal effect. It's well demonstrated in cancer. It's got several important studies showing it can also happen in HIV, but it's a little bit less well reproduced. And so what happens is if you have antibody and antigen, in this case virus, together in immune complexes, those immune complexes get taken up by antigen presenting cells, and they allow B cells and T cells to have more evolved, better, more potent responses against that specific virus. And so the goal is with antibodies and antigen, we might be able to enhance other immune responses. And so I'm just going to talk about one trial that came out recently. There's several in the world of early antiretrovirals or at the BNAbs at the time of ART initiation, but this study is recently presented. I think it's going to be published very soon, and it's called the RIO study. So the RIO study looked at giving people broadly neutralizing antibodies either after early ART or after after antiretrovirals during either primary infection or after early ART infection. So as long as people were either in primary HIV or had a CD4 count over 500 cells per milliliter, they were deemed eligible to receive this therapy. And so what we saw with RIO and in these other studies is an increased frequency of post-treatment control. So here's the schema for this study. 72 participants were enrolled. There were two groups, a treatment group that got BNAbs and a placebo group that did not. And then they underwent a treatment interruption. But the interesting thing about this clinical trial design is for the folks who were randomized to the placebo arm, they underwent a treatment interruption. After they rebounded and restarted their antiretrovirals, they were offered the BNAbs at that later clinical juncture, which is this interesting clinical trial design, which allows for all people in the study to have the option of one intervention or another. Now, that second part of the study has not yet been presented. It's still ongoing, in fact. But the first part of the study, this has been presented, and I want to share the preliminary results from stage 1. So this is the Kaplan-Meier curve looking at the time to rebound. In blue, in the participants who received BNAbs, and in red, the participants who just underwent a treatment interruption after relatively early ART initiation. And so they got very long-acting BNAbs. And so if we look at week 20, that point in time, we still think there's some BNAb activity. And so what we see is that the BNAb treated individuals, 75% of them maintain virus control, whereas the placebo treatment, only about 10%. And so that reflects the difference between ongoing BNAb control versus just treatment interruption. But then if we look later at week 72, which is long after the antibodies have left the system, what we see is there maintains a substantial proportion of these individuals who got the BNAbs at the time of ATI who retain their virus control, suggesting we may have enhanced that post-BNAb, post-intervention immune control. So if we look at the viral rebound kinetics from these individuals, it gives us more of a sense that there's some different things going on. So this is just looking at the rebound curves for the individuals who received the broadly neutralizing antibody. About a quarter of them have very normal viral rebound shortly after their treatment interruption. And this reflects virus that was not impacted by the BNAbs, perhaps highly resistant to those antibodies. We see normal exponential growth of that virus, just like we see in our placebo arm. So about a quarter of the people probably had very little impact from the antibodies. About a half of the individuals had delayed rebound with this sort of oscillating or low-level virus rebound. And this probably reflects delayed rebound in the setting of those BNAbs waning or getting smaller or having lower concentrations and less ability to control the virus. And probably there's also some immune boosting that goes on with this, because this is not the typical virus rebound, that exponential growth that we see. And then in a quarter of these individuals, what we see is long periods, more than a year of virus control, and minimal, if any, virus return at the time when they do have some detectable rebound. And so this is the group that we think probably had a boosting of their immune responses from those BNAbs, and it may be closer to what we are looking for in terms of this post-treatment control. Okay, so in conclusion, what I'm hoping we can say here, as you've just explained all of these just crystal clear points about HIV cure, and your patient will say to you, thank you so much. It is great to hear the progress about HIV cure. I now have a better understanding of how HIV persists despite really effective antiretroviral therapy. I understand that gene therapy holds promise for a future HIV cure. I understand that some people, a rare percentage, can control the virus naturally, either in primary infection as a lead control or after treatment interruption as post-treatment control. And I understand that specifically early antiretrovirals and BNAbs either at or after early antiretrovirals show a lot of promise in leading to ART-free virus control. All right, thank you very much.
Rather sit or stand? Okay, why don't you sit? All right, we now have time for Q&A for Dr. Barr. And as you heard earlier, you can either ask questions using the Slido system, or you can write on cards or come up to the microphones themselves. So let me just ask you the first question. You didn't talk a lot about this, but there have been a number of studies that have used combinations of BNAbs. And what are your thoughts on whether we need combinations of BNAbs in this setting, and what those might look like for the future? maybe that's a loaded question, but
No.
I know you've done a lot of work in this area.
Yeah, this is one of the areas I spend a lot of time in. So the short answer is yes. We most definitely need combinations of BNABs, both in the prevention space, in the treatment space, and in the cure space. And there's a lot of different sort of mechanistic reasons for why. In the prevention space, we really, if we're going to use BNABs for prevention, or if we're going to induce BNABs via a vaccine for prevention, which is still a real hope for the field, we probably need multiple specificities to be able to counter the extreme diversity of HIV that's in the world. So we just need multiple BNABs to be able to have one or two that are able to block virus in the prevention world. When we think about BNABs for treatment, I think the current strategies in develop right now that have an actual clinical possibility are more likely to be a long-acting BNAB plus a long-acting antiretroviral. And those in combination could be delivered every 6 months right now, perhaps even less frequently in the future. And I think those have an opportunity, but it's still a combination to be realized very soon. In the cure world, when we're trying to have full suppression of the virus, as well as engage those effector mechanisms, it's a little bit more controversial, or it's a little less clear whether you need multiple specificities, because if you want to restrict the virus, yes, you need multiple specificities to have extra activity. But if you want them to serve sort of an immune role, you may not need to have you either need to have multiple BNABs to protect them from resistance, or you need to combine those with other immune effectors to protect those antibodies from resistance. So yes, combinations are very important in all of our applications of BNABs. The field is working to design those combinations, but honestly, the recent political realities and financial realities have, like many areas, sort of slowed the development of very promising BNABs to sort of clinical availability.
And another question that occurred to me while you were talking is, obviously you're showing a great deal of important effects of long-acting BNABs given in the space of acute infection. I guess looking at your ATIs, in the long term, do you foresee an approach where we're using maybe intermittent long-acting BNABs to maintain virologic control without antiretroviral therapy? I guess you can call it a form of ART, but yeah, basically once a year BNAB injection like we're doing with some of the long-acting antiretroviral drugs. Do you see that as an approach for some of these people who are able to maintain control for long periods of time?
Yeah, I think that's a real hope for the field, is that we would be able to either passively administer long-acting BNABs at a very infrequent pace, but even more durably, that we'd be able to deliver them by gene therapy. So we could deliver the ability for our own cells, B cells, muscle cells, what have you, to produce antibodies. And that's a one-shot, in theory, a one-shot approach to have long-acting antibody delivery that would both be an antiretroviral and, in theory, continue to engage the immune system to help counter HIV in addition. So there's a lot of exciting work on sort of vector delivery of BNABs that I think has the potential to be one of those one-and-done cure strategies, which is really one of the goals of the cure field, is to have this be a more permanent intervention, as opposed to having people be dependent on continued clinical care, clinical infrastructure, international payers, et cetera, which is obviously a huge concern in our modern reality.
Great. So one more question from the audience. The CRISPR-Cas system is one of the questions that comes up from patients a lot. They hear about it on the news. And what do you think is next with that approach to cure?
Well, there's actually a huge range of technologies that are being built off the CRISPR-Cas9. So it's not just the exonuclease and homologous repair. There's a whole bunch of new sort of exonuclease strategies that can lead to different ways of excising safely a bit of genetic material. Obviously, it's a huge burden to ask for any sort of exonuclease approach to eradicate all the virus within our entire cell population. But there is a lot of, in the rest of the biomedical world, people are really looking at these sorts of strategies. And I think we're going to be able to all, as a total biomedical community, learn together. I will say the phase 1 study that was recently reported looking at CRISPR-Cas9 in adult humans was safe. And that's probably the most important thing, because there's a lot of hesitancy and anxiety about how these approaches may have off-target effects. There were no perceived off-target effects. There was perhaps a little bit of activity from the CRISPR-Cas9, but it clearly fell short of the bar that's needed. So I think there's a lot of promise in this world, multiple barriers or multiple continued challenges. But again, it's another approach that could be part of a single administration that would then relieve some of the long-term burden of continued care.
Thank you. Another question from the audience. Current guidelines continue to recommend ART for elite controllers. Do you think this is necessary if a patient has natural immune control?
That is a super interesting question. There's a whole range of, quote, of control when we see elite control. And for people who have even low-level virus production, there is increased inflammation. There is comorbidity associated with that. And so I think that's a really good discussion for each elite controller and their provider to say, what is the benefit of continued antiretroviral therapy, considering what my personal scenario is? It is recommended to start antiretrovirals in elite controllers. And we do see reductions in low-level viremia and markers of inflammation that have important clinical correlates. But then you sort of juxtapose that with the fact that this is kind of the goal of our cure response. And that's sort of thinking about individual care versus population level care, like population level approaches. And so I do think that specific each individual elite controller with their level of control, their own sort of understanding of what antiretrovirals entail and what their ongoing natural control entail. It's a really good discussion for an informed provider-patient relationship.
And this is maybe a variation of that question, but does viral load play a role in the effectiveness of BNAB approaches that you're looking at now?
Yeah, so the more viral load means the more cycles of virus replication. And anytime we have an intervention, be it an antiretroviral or an antibody, the virus is always looking for ways, we're going to anthropomorphize the virus, but the virus is always attempting to develop resistance. And so the more virus replication, the more random mutations, the more chance to select for a resistant mutation. And our modern antiretrovirals are so good at being resistant to development of resistance because the number of mutations and the fitness costs associated with resistance is very high. Our antibodies aren't there yet. And so it's easier to develop resistance to our antibodies. Therefore, a high viral load makes it more likely to develop resistance against BNAbs in a way that was probably relevant in our early antiretrovirals, but not as much with our current regimens.
This next question has maybe a little bit of two parts, but kind of about the pharmacokinetics of BNAbs. So drug delivery and stability of BNAbs has been a problem with some of them. And have we evolved with BNAbs to the point where we have better stability, better drug delivery systems? And if so, what is the cost?
Yeah. I'm not sure I'm going to answer this question exactly as it was intended, but one of the major issues for some of our most promising antibody BNAbs is their manufacturability, and that the way they act in the lab, the specific formulation is oftentimes difficult, expensive to generate in large quantities. And so the science, the sort of protein manufacturing science of how can we slightly modify those antibodies so that they're less expensive and more easy to generate at a very high level, that has improved in HIV, but also across the board when we think about all of the sort of antibody-based, monoclonal antibody-based therapies that are being developed right now. Yeah.
I think that's about as good as you could get with that question. So I don't think we know what are going to be the true costs of BNABs until we have ones that really go into sort of clinical practice. So on a related topic, who is financially supporting CURE now? Are there companies that are producing BNABs now that are supporting research, or is this primarily investigational lab-based approach?
That's a very interesting question. So, the NIH is committed to continuing, at least at this point in time, HIV cure research. And so we all, as we need to advocate for all of the HIV research services, et cetera, I think cure research is currently, everything's precarious, but it's currently being supported. There are several companies that are heavily invested in HIV cure. Several commercial companies have BNABs that they're developing for cure approaches. They have immune modulators they're developing for cure approaches. They have latency reversal agents. They have novel compounds that do things like attempt to have cells recognize the virus within them and sort of trigger an apoptosis or pyroptosis type approach. So there's lots of different ways that is being supported, in particular by the large sort of pharmaceutical companies that we think of being involved with antiretroviral therapy. There are smaller companies invested in sort of the gene therapy space. That's the glass half full version. The glass half empty version is that there are a lot of groups that have recently gotten out of the sort of HIV research and development, cure, translational therapy approaches. And so, hopefully the world is a little bit more favorable to these sort of things being financially reasonable, and then we'll get more investment. I will lastly say the Gates Foundation continues to be invested in HIV cure in quite a number of ways. They support trials throughout the world, and they have a lot of interest, in particular, in the sort of gene therapy one-shot approaches and continuing to develop those as a way. And I think when you think of global public health, the last year has been, very sobering in terms of we're delivering antiretrovirals to 30+ million individuals, but that requires a lot of infrastructure, a lot of continued support, et cetera. And if that is unstable, can we think of a way to have people get good HIV treatment and care or cure without that continued reliance? And so the concept of a one-shot cure or long-lasting HIV remission strategy has a lot of public health and sort of international financial benefit. So that's one of the things I think the Gates Foundation is in particular looking at.
So we're going to have to close our Q&A now to go on with our program, but thank Dr. Barr for a wonderful presentation.